Group Education of the Pregnant Hispanic Community, University of North Carolina at Wilmington, Nursing 408, Community Assessment Project, Presentation and PowerPoint by Michelle Lopez, Katherine Sonopoli, and Cortney Sirois. Introduction. The community represented by this presentation is the pregnant Hispanic women attending a low-income OB/GYN clinic in Charlotte, North Carolina. This presentation will look at the demographics of Charlotte-Mecklenburg County as a whole, with a concentration on the 28213 zip code. We performed a windshield survey, found that access to public transportation is great. There's buses and the Blue Metro line. Sidewalks are apparent throughout most of this community. Due to major road construction, some sidewalks are, however, in poor condition. There are many apartment buildings and small homes, multiple gas stations that have EBT signs displayed in their windows, many closed and abandoned strip malls and grocery stores, which provides or limits our patients from having fresh access to fresh fruit, vegetables, and meats. Homeless citizens are on the roadsides and at intersections with signs, and there is a large presence of police in this area. Demographics, languages. This zip code is 63.3% English speaking and 31.2% Spanish speaking. Other languages that are represented include French, Vietnamese, Gujarati, Korean, Italian, African, and South Asian. Demographics, ethnicity, from largest to smallest. Some of the ethnic backgrounds include Mexican at 19.2%, Sub-African 12.4%, Central American at 10.2%, African at 6.5%, and Puerto Rican finally at 4.7%. Demographics, we have two pie charts here. On the left shows marital status and on the right shows age. The marital status, the first group with the highest percentage there is single, never married, followed by married group. Third comes in divorce, and finally is widowed. And the actual percentages of those are married is 26%, single, never married is 47%, divorce is 18%, and widowed is 9%. On the right shows age, and the ages that are primary in this community are 5 to 17 and 30 to 44. 30 to 44 is 26%, and 5 to 17 is 25%, so very close there. Following closely is the 18 to 29-year-olds, which is at 18%. Then we have 45 to 64-year-olds, which is 13%. Then we have under 5-year-olds, which is at 12%. And finally is our 65 and older population, which is at 6%. Charlotte-Mecklenburg crime statistics for the community. There were 47 homicides that were reported compared to 32, which is an increase of 46.9%. 1,335 robberies that were reported compared to 1,173, which is an increase of 13.8%. There were 223 rapes that were reported compared to 190, concluding in an increase of 17.4%. 2,746 aggravated assaults that were reported compared to 2,304, resulting in an increase of 19.2%. Burglary overall was up 16.7%. The numbers there are 4991 compared to 4275, with an increase of 15.9% in residential burglaries, 3666 compared to 3163, and an increase of 19.2% in commercial burglary cases, 1325 versus 1112. There were 1,635 vehicle thefts that were reported compared to 1,203, which is an increase of 35.9%, quite a big jump there. Total larceny cases increased by 5.4%, 17,540 compared to 16,642, with the larcenies from auto up by 9.4% alone. The numbers there are 6,462 compared to 5,909. And finally, 184 arson cases were reported compared to 124, resulting in an increase of 48.4%, which is huge. Community diagnosis, weaknesses. There is a large number of young pregnant women with very limited financial resources. The limited finances may mean lack of access to overall care and education, housing and transportation, and nutrition and safety. Community diagnosis weaknesses continued. This is a non-English speaking population, and they may have a low level of health literacy. In this culture, men make the majority of the decisions, which makes women hesitant to make their own choices concerning their pregnancies. Community health diagnosis strengths. This Hispanic community sees health as a community issue and needing community involvement, not an issue to be held independently or even within the immediate family. Therefore, patient education becomes community education. This strength is what we are basing our intervention on. We want to have the group visit to provide information as well as correct any misinformation that may be present within the community. And by utilizing the group model, we can be more aware of any misinformation. And this also allows women in the group with similar experiences and at a comparable gestation in their pregnancies to reach out to each other via social networking. This network should continue to grow past the point of the pregnancy, and the patients can continue to support each other in the postnatal period, and their children can even experience stages of childhood together. Community health diagnosis strengths continued. This population spreads information throughout themselves. Therefore, education to a group of people would likely benefit many within that same community. Interventions. We've got a primary intervention to initiate group visits to the Spanish-speaking women at the OB/GYN office within the first trimester of pregnancy. And we chose the first trimester because we felt that there's a lot to be learned in the first trimester, and a lot of these women haven't been pregnant before, and they're adjusting to their bodies and their bodies adjusting to pregnancy. So there's a lot of education that can go on there. Secondary intervention includes gaining financial support and additional resources from local businesses in the community. And third, we'd like to push for support at the state and federal levels, continue to implement and grow the model, and seek out policies and resources intended for this population that are underutilized due to a lack of knowledge. Finally, we have some questions here. Are there any potential or actual problems in this community? And yes, there are a large number of young pregnant women with very limited financial resources who may not have a very high level of health literacy and may have some unsafe practices related to their health and their pregnancies. What areas are affected by these problems? And all areas are actually affected in some way by limited finances and limited health literacy. There's the access to care, transportation, education, nutrition, safety, housing, crime rates, and much, much more. What is the level of community awareness of identified problems? Well, community awareness is variable. Some have no knowledge of a problem, while others have high awareness and blame the community, and still others have a mindset that this is what it has always been and what it will always continue to be. Are the problems considered high priorities by the community? Awareness is crucial to the prioritization of pregnancy care and women's health in the community. Our priority is to increase the level of health literacy so that the patient and community can begin to advocate for themselves as well as for the community as a whole. In addition, there needs to be allocation of resources and knowledge of available services. And asked to identify potential nursing and or other health interventions to address these problems. And nursing education is certainly number one. We as nurses have the knowledge and interventions needed to create a change, but these patients must be educated in order to work with their healthcare team and their community to make positive changes. And finally, this last slide here shows our resources. We use the Centers for Medicare and Medicaid Services. We use Charlotte-Mecklenburg Police Department statistics. We used Neighborhoods Scout.com, which had demographics relating to Charlotte, North Tryon Street, and North Carolina in general. And then finally, we used Women's Preventative Services coverage and nonprofit religious organizations, also from the Centers for Medicare and Medicaid Services. And we'd like to thank you for watching our presentation and hope that you enjoyed. Thank you.